Hi, this is Dusty Lynn, the Pediatric Educator at the Life Support Learning Center, and today we're going to go over a brief review of the Zoll defibrillator in the neonatal ICU. In our healthcare environment, you will find that there is one device, the Zoll R series, and there are two default configurations. One is for pediatrics, whereby every time you turn it on, it will default to 1 joule, and the other is the standard configuration for adults that defaults to 120 joules when you turn it on. You will notice that there are two tags of different colors. One is red, indicating it's the 1 joule configuration, and one is blue, indicating it is the 120 joule default. It is very important to know which defibrillator you are using so you will know what the defaults are set at. There are 3 titles on the tags. One will say NICU-PICU, one will say OR, and the other will say the standard configuration. The bottom line is, whichever defibrillator you find that you are using, always ensure what mode you're in. You'll need to know, are you in defib mode, are you in sync mode, or are you pacing? In the cases of defib and synchronized cardioversion, you need to know that you have the right joules programmed. Always check that. Do not make any assumptions. Always check to make sure. And in the case of synchronized cardioversion, you want to make sure that you've highlighted the R wave, because that's where it's going to send the electricity. The other final thing to make sure that you ensure before you press shock in the cases of defib and sync would be that no one is touching the patient. There are 2 different types of configurations based on the defaulted joules, as we said. The standard configuration, here you will see the dark blue tag, and that's mostly in the adult areas. And the middle tag is red, that's the NICU-PICU. You'll find that throughout the pediatric areas on the 7th floor. And then the OR configuration is also defaulted to 1 joule. Please note that in the battle building, they have the standard configuration. So if for any reason it were used for the pediatric patient, you would always need to make sure you've adjusted the joules to the appropriate level. If you go through this in your mind as a checklist before you ever discharge a defibrillator, you will avoid serious issues. Make sure you're in the right mode, you have the right joules programmed, and that you're on the right waveform when you're synchronized cardioversion. Here's examples of 2 defibrillators, and you'll see the different tags that are on them. The one on the left is the standard configuration that when you turn it on, it's going to start at 120 joules unless you change it. The one on the right, the red tag says NICU-PICU. It will default to 1 joule, and it will need to be increased for the appropriate level for your patient. Again, just to reiterate, the red tag means that its default is 1 joule, and you will change it as needed. You'll find this in the NICU-PICU and all throughout the 7th floor. The OR configuration also defaults to 1 joule, and you'll see that in the operating room. Equipment that you'll need to have with the Zoll defibrillator are the pads, and you'll have 2 choices in the neonatal ICU, because the Pad Pro mini infant pads you can use for babies who are less than 3 kilos. These are smaller pads, they take up less chest geography, and so they work well. Please note, you absolutely cannot use these pads in any baby who is 3 kilos and above. The joules are not rated for that kind of electricity, and it would be very dangerous to use those. So again, the Pad Pro mini infant pads, less than 3 kilos only. For all other babies, and for smaller babies if you would like, you can use the pediatric 1-step pads. those have the little puck that tells you how far you're pressing the chest down. They're fairly large. You can actually pull off that oval pad with the cross on it if it's taking up too much room on the baby's chest, and you can pull that right off and just use the front to back pads. You'll also need the 3-lead ECG cable for most therapies, and that should also be on your defibrillator. There's 3 modes that you can use the defibrillator in when it's in manual mode: defibrillation, synchronized cardioversion, and pacing. To defibrillate, we usually use a starting joules of 2 joules per kilo. Place your pads on your patient. The ECG cable is not necessary. It's often good to go ahead and put it on the patient because, for example, if you're in VFib, you shock them out and now they are in VTAC and they have a pulse. You will need those cables when you synchronize cardiovert them. So go ahead and place them on early, and that will save you from having to fumble for them. Turn your device to defib. Go down and press your energy select, the arrow up, because it will start at 1 joule. When you're using the red tag, NICU PICU configuration, put it on the energy select that you would like. Press the charge button. At this point, your eyes should definitely be on that patient. Let everybody know what's coming. Tell them in advance. Shocking on 3. CPR should now be halted. Eyes still on the patient. When you do your countdown, 1, 2, 3, press the orange button, shock, and then CPR should be continued. You might use the defibrillation mode when you have a patient who's in pulsus VTAC or a patient who's in ventricular fibrillation. The other mode you might use is synchronized cardioversion. We usually start off at 0.5 to 1 joule per kilo. Place your pads and your 3-lead ECG cables on your patient. You will notice that you cannot find the sync button until you turn it on to defib. Once you turn the knob to defib, the option for sync comes on the bottom right of the screen. You will press that button. When you press that button, once it puts it in sync mode, it will show you where it is going to send the electricity. You need to visually confirm that it is on the R wave. You might have a situation where you have a patient who has a negatively deflected QRS, and it might highlight the T wave. You, of course, are not going to send electricity on that, so you need to change the lead. You'll see that button on the right, or change the size to make it very apparent that you are on the R wave. Once you've highlighted the R wave, go to your energy select, decide if you're starting at 0.5 joules per kilo or 1 joule. Energy select to where you want that, press charge. At this point again, you need to let the team know, even though CPR is not in progress at this point, but you need to let the team know that you're getting ready to shock. Your eyes will be on the patient, shocking on 3. 1, 2, 3, and press and hold the shock button. You have to hold it for a few seconds till it sees the R wave and then it discharges. The most important thing I'm going to tell you is right now, make sure that you realize that once you push the shock button in the sync mode, it reverts it back to the default, which is defib mode. So always check to make sure you're at the right mode, on the right joules, and on the right waveform. Otherwise, you can inadvertently defibrillate this patient and actually put them in VFib. So recognize that once you push shock in the synchronized cardioversion mode, it will default it back to defib. So you'll need to push the sync button prior to using synchronized cardioversion every time you need to do that. So the pacing mode. Here you'll place the pads. You absolutely have to have the 3-lead ECG cables on the patient. You turn your knob to pacer. And at this point you should verify that you see pacing spikes across the screen. It's just showing you that it's ready. If you need to adjust the rate Depending on the size of the patient, oftentimes in small infants, we will start the pacing rate at 100, but follow whatever your team is choosing. And if you decide to go up, take the pace beats per minute knob and turn it up to the rate that you want. The pacer is still not going yet. It's just showing you, as evidence on the screen and the pacing spikes, that it's ready to go. You will activate the pacer by increasing the milliamps until you have good capture. So the milliamps, or the output knob, you will increase. Good capture looks like everything is uniform across the screen. You'll see a pacing spike and you'll see capture, an immediate response after pacing spike and response. Recognize that with a defibrillator, manual defibrillator, in the pacer mode, you are externally, ventricularly pacing. So you'll see a pacing spike, and if it's captured, you'll see this oftentimes wide and bizarre, not always, but often, response to each pacing spike, and it will all look the same. Once you see that it's good capture with every pacing spike, at that point you need to verify that there's good mechanical capture. So you would go to feel for a pulse in your patient. It should feel and correlate exactly to what you have the rate at as well. You should, maybe if they have an arterial line, see an increase whip in your waveform, or your rate will now match what your pace beats per minute is. If you are pacing this patient and he has an increase in cardiac output, which he should, once he has a good capture and he has increased perfusion, he may start crying. If he starts crying and his heart rate goes above whatever your preset rate at your pace beats per minute is, the pacemaker will stop, because it's only on demand that it needs. So your ECG is going to look a little different once he goes back to his intrinsic rate, if he's able to do that. So just note that if the ECG starts to change and looks a little different, if the rate is higher than what your pace beats per minute, that's his intrinsic rate, and it may look very different. It should look very different than his pacing rate, rhythm. However, recognize if this child is in a 3rd degree heart block and he cannot raise his heart rate above, say this is a newborn whose mom had lupus or some other reason why he's born with a congenital heart block, he will not be able to increase his heart rate. So he's totally pacer dependent, and his heart rate will always be whatever your pace beats per minute is. And recognize this is a temporary external ventricular pacer. Again, always make sure you're in the right mode, you're at the right joules, and on the right waveform when you're in synchronized cardioversion before you press the shock button. I'm just reiterating the first 2 modes as we talked about them. In pacing, you do not have to worry about touching the patient. You should be able to touch them with no problem. Let's talk about a couple of situations that you might be in that are very special. We'll talk about the standard configuration ZOL use in the infant, and we'll talk about the NICU PICU configuration use in adults. If you find yourself somewhere within the facility and you need to use a ZOL and you do not have one, and all you have is a standard configuration, you absolutely can use it on your neonatal patient. You need neonatal pads or pediatric pads. If you don't have that, you can use the adult pads. However, it is absolutely mandatory that you have this in the manual mode for defib or synchronized cardioversion, and not the analyze mode. Analyze is the same thing as AED, and it commandeers it, and in the standard configuration will shock them at adult rates, which you do, adult joules, which you do not want to do. So if you're using the standard configuration, use the pads the best you can use for that patient, and always make sure that you've checked the joules and turned them down to what you need for your patient. If you have an adult patient in the NICU that is a pulsus and CPR is in progress and someone needs an AED, you can use the ZOL that you have in the NICU PICU if you can't get the code team there. Just recognize you absolutely have to have adult pads. You would never put pediatric pads on an adult patient. Once you do that, whatever mode you put them in, analyzer, manual, just recognize that it's only going to be 1 joule, which is nothing for the adult, so you'll need to increase it for whatever therapy you're giving. When in doubt, look at the top of the Zoll and it will show you what the adult joules would be for each rhythm that you are trying to treat. So just refer to that. Again, always make sure you're in the right mode. You have the right joules programmed. You're on the right waveform if you're in sync, and that no one is touching the patient. Thank you for listening. I hope this was helpful. Please feel free to join us at the Life Support Learning Center, where we have classroom experiences where you'll have much more in-depth information and have a chance to practice on the Zolls with neonates and pediatric patients.